it's my pleasure to present our next speaker, Dr. عاصم الشنبري. Dr. عاصم is an assistant professor at Al University. He's a consultant of geriatric medicine and care of the elderly. Dr. عاصم will give us a talk about the implementation of a training program to increase knowledge towards patients with Alzheimer's. So thank you, Dr.
Even the remote is very nice, color-coded. Thank you. طيب, بسم الله الرحمن الرحيم. First of all, thank you for coming, and thanks for the organizing committee for this kind of gathering and having those geriatricians all together in one place with this kind of big conference. It's, for me, actually, it's a chance to meet my colleague, meeting residents and medical students, talking about the new medications, new way of diagnoses. I was hoping to talk about something like scientific about a topic, polypharmacy or something like that, but they chose this topic for me. It's very interesting. What I'm going to discuss today is like overview about Alzheimer's disease. I think this topic is kind of now, even the prevalence, we already, my colleagues actually highlighted on that. So what I'm going to discuss, first, the first part of the presentation, I'm going to talk about the local studies about the awareness. We will see in different regions in Saudi Arabia how they are doing there, what is their awareness community-wise, also healthcare workers, students. Then we will see the challenges that we are facing in this field. After that, the other part of the presentation is going to be about the suggested interventions to increase the level of awareness. This topic, I was preferring that we have it as a workshop. We have a chance now, we have a lot of experts, with long experience, mashallah, better than me, discussing that. So what I'm going to present, it's from my, perspective, from my experience. However, it's fruits for thought and things that we need all to work on. So I will skip this, even the numbers. Let's talk about the local studies. This is a nice one regarding the public awareness, knowledge, attitude toward Alzheimer's disease done in Asir region, done by Dr. Adil. It's a cross-sectional study, was carried out by Dr. Hazzani and the core worker to observe the public awareness, knowledge, attitude, and the Alzheimer's disease in Asir region. They have electronic online, semi-structured, and self-administered questionnaire randomly to be distributed among participants. The questions include socio-demographics, attitude, and knowledge panel toward Alzheimer's disease based on the Alzheimer's disease knowledge scale. The participants, they had a good number, 1,374 participants with age range from 18 to 70 years. So the majority of the participants, 77%, had no family history with Alzheimer's disease. Less than 50% of the questions were answered correctly, and mean knowledge score was 10.7 plus minus 5.11. The results is the important part that we're looking for. Reveal that young-aged participants, females, and those having family history of disease having significantly better Alzheimer's disease-related knowledge. The study revealed an inadequate knowledge as indicated by low mean knowledge score. So we're talking about Asir now. Other study that was kind of like around Saudi Arabia. So they used the same scale, and the results, the participant didn't have a high enough mean score to be regarded as appropriately knowledgeable, and higher knowledge scores on life impact, risk factor assessment and diagnosis, caregiver, treatment management, and the scale associated with female gender. Higher knowledge caregiving was associated with postgraduate academic qualification, and higher in those who have a relative with Alzheimer's disease. The other interesting part about this, the information that they had it was through the newspaper, journal articles as the source of medical information. Other study that happened in Mecca region. So it was a descriptive cross-sectional studies conducted in August 2018 in 3 cities, Mecca, Jeddah, and Taif. Valid and reliable Alzheimer's disease, which is the same scale that used in the previous articles. The study included 862 adult participants. Their age ranged between 18 to 65 years. History of having a relative with Alzheimer's disease was mentioned 20.8% of participants. Overall, the percentage of total Alzheimer's disease knowledge score ranged between 26.7 and 100%. There was a significant positive correlation between participants' age and their knowledge regarding Alzheimer's disease. Participants who reported a history of having a relative with Alzheimer's disease were more knowledgeable regarding symptoms than those who didn't have such history. Another article, evaluation of knowledge of Alzheimer's disease among health universities. Now are talking about medical students, and also think other health students. So that was conducted by an online questionnaire for pharmacy, medical, dental students at King Saud University in Riyadh. So the participants were 671 participants. Most of the respondents, 373, answered correctly and said that Alzheimer's disease is related to mental disorder. Although the majority of 73.5% knew the Alzheimer's disease is a neurodegenerative disease. The Saudi health care students have variation in knowledge about Alzheimer's disease. The knowledge score was lower in dental students compared to medical and pharmacy. The last one, it's about the extent of and influences on knowledge of Alzheimer's disease among undergraduate medical students. The summary of that, the undergraduate medical students lacked proper knowledge of Alzheimer's disease. And the suggestion was about the improvements in education programs that can be helpful. So as you see, for the community, medical students, healthcare students, even doctors, they have a little bit, they don't have that much about Alzheimer's. So when we are talking about increasing the awareness, we have to consider each individuals where in the community, what should we do? In the student-wise, what we can do for the residents, for the relatives. I think studying the best way how to reach them, it's part of the thinking about increasing the awareness. I'm working in al-Qura University and Baterji Medical College. As an academician, I was working to see where I would fit geriatrics in the curriculum, which is the part that we need to consider in all universities. Unfortunately, we don't have well-constructed module for geriatrics. Even if you think about it, home health care, it's not part of our medical students' curriculum. we are teaching our students how to manage a patient in clinic, outpatient, ER, inpatient. However, we are not teaching them about the specific info, giving them specific information about how to take about elderly, specifically those with Alzheimer's disease, or taking care of patients at home. So the main goal to increase the fund of knowledge in geriatric medicine. So the focus, it was on the aging physiology and disease common to elderly adults, particularly complex medical and neuropsychiatric syndromes such as dementia, falls, and delirium. Improve skills in geriatric assessment, significantly medically oriented physical examination. Expanding the ability of integrate clinical, cognitive, functional, and social assessment data into treatment and management plan, optimizing care of elderly. A 2.5 round in nursing facility. So our experience in Marghera University, it was positive. For the last 3 years, I applied the same thing in Pathology Medical College, having the physiological changes integrated, even the basic science, what's going to happen once we get older in the perspective of physiology, anatomy, having that, and even like for all the physiological changes that happened. But talking about this, it has to come from basic science toward clinical years. Other thing, in fellowship, the objective should be, advance a little bit. So here, the objective is to train physicians to care for older adults, to provide trainees with knowledge, skills, confidence, to be highly qualified geriatrician, be exposed to an extensive experience in geriatrics with elderly individuals living at different levels of care, maintaining a longitudinal panel of patients in each clinical setting that a geriatrician may practice, including office-based, long-term geriatric assessment, and home care. Okay, so here we are talking at the level of medical college, residency training, and fellowship, which is the thing, I think it's important. The other interventions that what I'm going to discuss is areas that we need to enhance it in the medical education. Let's talk about the first one, about the communication strategies. The communication here, it's not only communicating like patient-doctor relationship or patient, it's all about patient-family, the doctor with the family members, the doctors with the other doctors. This is another part of communication that we are lacking. So I can see other specialties. They are prescribing medications without looking at the drug interactions, looking from their perspective of treating the disease, not looking at the life expectancy of the patient. So as a geriatrician, we are facing this kind of problems. Previous lectures, we were talking about big tube feeding or NG tube feeding, placing big tube, keeping the patient on NG tube for more than 6 weeks, increasing the risk of having, this patient to be dependent on NG tube or big tube. So the communication part, it's important to consider all of that aspects, not only the communication part with the doctor and the patient, or the doctor with the family. Other thing about the communication is the how to communicate with the family in different stages. So early stage, how to do like breaking the bad news to the family. We need to have this kind of workshop for our students, residents, even consultants, is very hard. I remember one of the cases that I had. a young, actually, a person came to me with his mother. And I was like diagnosing her with cognitive impairment. After having all the labs, all the imaging, then I told him to come to discuss the case without his mother. When he came, from my experience, I used to slice the informations, trying to see their reactions based on their reactions. His reaction was totally unexpected for me. He was solid, having all the news about his mother. Then I was like, okay, he is good. I will go more. Then I gave him all the information, all the stages. Then he was like, he broke. He was crying like a child. Wallahi, at that time, I realized, what to do? Is it my mistake to do it? But he was a kind of solid, listening very carefully. But I think it is difficult. It is difficult. If you think about it, your loved one wouldn't remember you at one time. So I think we need to work more on this kind of communication, breaking bad news. In al University, Pathology Medical College, it is one of the stations, and the students, they know it. It is one of the stations. Breaking bad news. I included, having dementic patients, how to, communicate with the family, how to break the news. Other thing, managing the challenging behaviors. How to discuss that with the family, how to convince them that with this kind of disease affecting the frontal lobe, the personality disorder might happen. How to think with the family about the solutions. I think the other part is listening to the patient. And this is what most of physicians, they don't listen. Just let them speak. Sometimes they would give you the ideas, but they would like to share it with you. Strategies of managing challenges, behaviors, importance of understanding the underlying cause of behaviors. How do you explain to the family that the problem with delirium triggered by constipation? They will laugh. Even like inpatients, a patient admitted to the hospital with that much of disturbance in the sleep cycle, with the medications, with the diet, with the environment, how to convince the family about this kind of changes might be temporary, it will be covered, we need to treat the underlying cause, he will be better, and we will reevaluate to see if he will come back to his baseline or not. So this kind of, it needs practice. This is what I'm trying to say. Caregiver support. Dr. Hashim spoke about this and highlighted important things about taking care of them, how we would give them time to explain. The challenging part here is that the caregivers, sometimes they don't want to talk about their burden. They think it is against bir al-walidain. They will feel ashamed if they say something bad about changing diapers. Or they get kind of like, they are tired. They are tired. And they cannot talk about it. They cannot say it. Culturally, it's wrong. Then you have to volunteer that. You would say, I understand your suffering. I understand. I know you are tired. From my experience, whenever I say that, wallahi دائما كلهم يبكوا. Because I touch very sensitive area that they cannot say it. The culture wouldn't accept that. How come you would say this? So taking care of the family, try to, as a family physician, I would start them, on antidepressants. trying to convince them that they need something, they need help, like sleeping, they need to sleep well, they need to, share their experience with others. That would kind of like relieve their suffering. Sometimes I would advise them to watch those movies. Still Alice, one of the best drama movie. Julia Moore, she did her best act on that movie. She was a linguistic professor in her 50s. Birthday, she started to have problems with finding word expression, how the family interacted with that, how the way that she accepted the fact she has familial type and of Alzheimer's disease. It's very nice. Even how she interacted with the symptoms, how she was wandering around because she was running like her usual activity, and she has a kind of confusion due to the dehydration. So how the family interacted with that. So that would a little bit help the family. Other movie, the greatest here, actor Anthony Hopkins. I love this guy. His way of act, even the director, it was totally different movie. It was because you will feel that you will have the feeling of lost during the movie. Then it shows you that how the Alzheimer patients think. So even like at the beginning, you'll be like, he's having visitors, and with each visitor, he is thinking him someone else. And you'll be like, what is this? So what is the truth? At the end, you realize this is what is in his mind. So it's very nice movie. لا أنا بس بقعد أشوقكم. أنا مدمن ترى أفلام فعشان كذا أشوفها بطريقة مختلفة. Personalized care plans. How to create personalized care plan for each patient. Importance of involving patients and their families in care planning. This is extremely important. As we see that even the medications, we don't have that much options. I was talking with Dr. Bandar and his speech about starting antipsychotic with the side effects. So the decision needs to be shared. Stopping the medications. What about the secondary preventive measures that we apply? Antiplatelet therapy, anticoagulants, statin. So this needs to be, you have to have a decision, but please don't make it by yourself. I always give the patient the option. So this is your option. Then I would face that, what if you are dealing with your father? I'll be like, listen, this decision, even if I'm in that position, I wouldn't take that decision. You have to sit all together, bring all the family together. And we will talk about the legal consideration of that. Dealing with one family member is not enough. It is not enough unless he has a legal custodian for that member. Otherwise, you will face a problem. Even the decision, whenever I have a decision, a big one, I will be like, can you bring the family to discuss it? Have you discussed it with your family? Have you discussed it with your brothers? If he said yes, can you bring them next time with you? So, and on top of that, it has to be documented. It has to be documented. Activities and engagements. So we need to increase the awareness that this is a very effective way. Personally, my mother, she did an exercise. She forced us. If you would like to visit her, you have to put the cell phone at the door. Otherwise, you are not welcomed. At the beginning, we were like, just texting. But then we realized it's kind of like interactive way of sitting with her and with my father, even the family. It's really unfortunate that they are considering visiting the family. I am with my mother. Seriously? So you were handling your phone, and this is not an interactive way of communication. And unfortunately, that would make the isolation more and more. I can see that even with the short time in my clinic, facing the patient, eye to eye, communicating with them, try to touch them and talking to them, they will feel happy because they are missing this part of communication, even from their kids. So do this with your family, with the patient, and ask the family members to do it. So this is the way that you would interact with them. Other activities that enhance the intellectual part. Thank you so much, Doctor, for mentioning that. It's really important that try to do kind of like exercise with them, like even having, let them write their diaries, share it with them, writing the day, the time, the type of food they are eating, the people that they are supposed to meet or they met. At the end of the day, you have to ask them, we are busy. We are busy, and even the family members, they are working most of the time, so they are away from their parents. So I do ask them that once you visit, you would ask your loved one to remember what happened that day, starting the day. You find a topic that you would share. Find a topic that even decisions for your own family, your small family, try to discuss that with them. Even with dementic patients, they have a feeling. They know the facial expression. Still, they are human beings. We are facing also difficulty like answering those kind of repeated questions. So I used to tell the family members, please don't shout. Even if you don't, your facial expression would tell. They know. They know, and they wouldn't do it again. And you will make the depression more and more for them. So interactive way of communication with the patients, even with dementic patients. Advanced dementia, it's important. Safety consideration. Safety consideration, it is part of this should be discussed in every visit, starting from wudu. So I used to ask my patients, how do you perform wudu? And you will be surprised. You will be surprised. They will do it as, like what they did when they were in 40s. But simple thing that you do would make a difference. Wallahi, I lost one of my patients because of fall in bathroom while she performed the wudu. Wallahi, it's sad, very sad story. So simple thing that you would do, simple awareness for our, residents, doctors, that please ask them about simple thing, wudu, how you are preparing it. So I used to let them do it. By the way, my parents, I was like, let me ask them to see. They were doing it like raising the leg, and I was like, alhamdulillah, basalt. Then simple thing, let them have a seat. And once they will sit, then they can have, washing their feet. The other thing about the safety, think about it from the stairs till the bedroom. So how many stairs, using the elevator or not, in the kitchen, specifically for those dementic patients who's independent on ADLs. So the kitchen is a risk. So you have to be careful. You have to apply all the safety measures, locking the kitchen, the bathroom. Do we have the grab bars or not? The rugs most of our, loved ones, they would prefer to put drugs all over the places. So, there is a lot of way that, trying to fix it or otherwise take it away. The light at night. So they would go to the bathroom more frequent. So be careful to, just mention it to them that the corridor from the bathroom to the, the bedroom, it has to be clear. It has to be, lighted all the night. How to respond to emergency situations. This is the other thing that you would consider, talking with the family members. They will feel more safe. I know it's going to be difficult. Honestly, most of my patients, they have my cell phone number, and they have only one. This is depends from doctors to doctors, but at least you need to give them a way how to get back to you in case of emergency. On the other hand, the emergency that happened, if it happened for the patient, how to make it easier to call for help for their sons. Safety buzz or a cell phone number with a single hit, so they would call, use it in case of emergency. They would call their kids. Emotional support. I think the emotional support needs to be, we need to start from the geriatrician. We need emotional support. Being a geriatrician, it is difficult. A lot of frustration. Dealing with the family members who are already frustrated and you're doing your best, treating their loved one, you will be depressed. Sometimes kind of like you'll be emotional once you see them suffering. And once you tried several modalities of treatments, non-pharmacological, pharmacological, and they're still having the issue, and they are coming back to you finding a solution. So you'll be frustrated. So you would rethink about geriatric fellowship. However, financially you will be fine. Home health care is expanding. We have more elderly people in the coming future. But on the other hand, you have to consider that you will be like, you have to maintain your emotions. Keep it away, but it's going to be difficult. The emotional support, I would mention listening to the family, listening to the patient, giving them time to speak is one of the things that it's kind of support that we would provide to them. How to support patients with families during end-of-life care. This is the other thing. People, they hate to mention something like that about hospice care. This patient would die in less than 6 months. You have to tell the family. I know it's going to be hard, but at the same time, what we are facing in private, that how we would comfort the patients in their end of life. We cannot manage the pain. I think this is one of the things that we would recommend, that we need to have, more flexibility in prescribing those medications who's suffering. So those patients, they will be in pain, then they will get back to ER, having more load on the health system. So flexibility is needed about those patients. Dr. Nabil, inshallah, he will do something for us regarding that. Legal and financial consideration. طيب 2 minutes. بس هذا أهم موضوع ترى. So the geriatricians, they need to consider, all the doctors, by the way. First you have to protect yourself, dealing with kind of like dementic patients or early dementia, and dealing with one family member. You need to protect yourself. As I said, you have to let all the family in. This is one point. The other point, the patient rights. Sometimes you will be the one who is fighting for his rights. Alhamdulillah, now we can see with the new vision 2030 that there is a lot of regulations protecting the elderly rights, but we need to implement it as physicians. Other thing about it, have you ever talked about advanced directive with your patient? This is the thing. I mean, we made this study, 2018. We made it in in Texas Tech University, where I did my residency. That was a cross-sectional survey study, was performed at 4 different departments, outpatient clinic, Texas Tech University Health Science Center in Amarillo, Texas. Patient over 60 who present during the 3 months time frame, in addition to demographic data plus the other informations. The sample size 314. We found that non-Hispanic patients with were significantly more likely than those of other racial or ethical groups to have an advanced directive in place. Married and widowed patients were more likely to have advanced directives. Those with greater than 12 years of education were also more likely to have advanced directives. Patients who received education from their primary care provider about advanced directives were more likely to have an advanced directive. So we need to do something about it. At least you have to tell your patients about, I mean, have you placed yours or not? الأعمار بيد الله طبعا, but I know it's kind of like depressed word to mention, like حط وصيتك. It doesn't sound right. But I think in geriatrics we need to talk with the, even asking, I do ask, who is living with you, taking care of you? By the way, sometimes I trust the caregiver more than the kids. I have most of the information from the caregiver who is sitting with the patient all day long. So you would trust them. You would know their wishes from the caregiver more than the kids. Almost done. Long-term care, technology, simple things about خرج ولم يعد. This is, as a geriatrician, we need to find them like a mild cognitive impairment. Those, they need triggers. And the exact time, صلاة الظهر, صلاة العصر. They will go there to the mosque with the sun, get dehydrated, they get lost. Then they will have the problem. So GPS tracker provided in Jarir, they would facilitate having tracking system for the patient. Dementia-friendly environment, this is a dream, صراحة. You would read more about Morse Life. I worked there for 2 months. Morse Life is a community-friendly community for elderly, and they have Alzheimer facility unit with 1 geriatrician there. It's a community. I mean, I would صراحة, if once I get older, after retirement, I wish that I would spend my life there. Well-established area, Morse Life in West Palm Beach, Florida. Itself, I mean, but I have to work more to have this kind of payment. It's not covered by insurance, so it's a self-pay. But you would read more about this community, and it is a good business model that might be new to our culture. شكرا جزيلا وشكرا على الوقت.
Thank you, Dr. Asim, for this wonderful talk. We have time for 1 or 2 questions before we do a group picture. So, are there any questions? I think there's a question here, Dr. Hashim, and there's a question in the back. Okay. Yes.
Thank you for this very kind speech for the last 3 sessions, the whole days. My name is Mustafa Ahmed. I established 2 referral labs since 1990s. I'm dealing with geriatric patients and some of them Alzheimer patients. And I have very good experience dealing with older people, male and female. I initiated a program called Home Service Phlebotomy, free of charge for older people. Just my question, there is a lot of, we have to look for geriatric medicine or Alzheimer as part of the geriatric medicine as whole view or holistic view or comprehensive view, considering a lot of multidisciplinary factors like psychiatric, nutrition, and emotional, including the nutrition itself, and pharmaceutical, and also, but there's some also spiritual, which Dr. Muhammad Khashim, he talked about in the first day. I believe we have to concentrate on the spiritual and cultural part of the treatment protocol or approach. This one part of it. The other part of it, I have got very good experience in hospitals dealing with such a patient as home service in the private sector. There is a lot of lacking of home service in the private sectors, in Riyadh at least, as far as I know, offering them with a reasonable, reasonable, acceptable price. It's very expensive to one of the well-known rehabilitation center in Riyadh, I was working with them for a while. They told me once home service for rehabilitation only for 1 month, daily visit for 1 hour, costs around 23,000 riyal, which is very, very, very high price, I believe. So I think there is a lot of things. Also, we didn't mention the last 3 days, small points, which is very important for geriatric patients or Alzheimer patient, almost the same, which is the insurance, medical insurance part of it. Nobody covered this point, and from my experience with the insurance companies, big one and small one as well, they are trying to avoid this kind of customer because it's risky for them, high risk for them, and it's guaranteed loss. And even in Majlis al-Dhaman Council, Saudi Council for Insurance, they are not emphasizing much on this point. If you want to insure somebody above 60 years old, almost you are talking about 15 to 20,000 riyal. Unless you can insure him if he is among a high number of groups, like 100, 200 as a private company or whatever it is. But if it's a small group or individual basis, it's very difficult to have for him insurance for older people. There is no reasonable acceptable above 15 and 20,000 riyal. Thank you very much for everybody.
I totally agree. So I think we can see that we need to do more toward increasing the awareness, starting from medical school, residency training, being part of the evaluation for dementic patients from geriatric perspective. I wish that our neurologist, we don't have neurologists here. Goodness. The thing is, like, a holistic approach that geriatrician would provide with like a lot of differential diagnosis other than Alzheimer's disease. So I think is a holistic approach from geriatrician that might be better. However, we need them. ونتعلم منهم أيضا. The other thing regarding the insurance, by the way, now it's covered. Alzheimer's disease is covered, I mean, under the medical insurance. And it has to be clear. You have to put an Alzheimer's disease as code, not a cognitive impairment code. The other thing, the home health care, it is under insurance now. Most of the services now is covered by insurance. I would say the labs for elderly patients in my practice, I'm running home health care as well. So it is covered by insurance. So this is, we are kind of like toward changing this, environment toward helping more elderly. By the way, they are doing this because it's a cost effective. I would reach them to take care of them using telemedicine. It's better than having them visiting me in the ER. That would cost the insurance more money.